You mentioned the term functional cure in one of the slides. How does that differ to minimum residual disease levels?
When we measure minimal residual disease, we look at that as something that can be measured at any point throughout treatment, at early stages, during and just after treatment. We know that, and there are a couple of techniques to measure that. We know that whichever therapy we use, well, for most therapies, that having a lower level of detectable disease early in a treatment course or after a treatment course will tend to prognosticate for a longer remission. Apart from with, say, ibrutinib-based therapy, when we know most patients still have detectable disease but can still have a longer remission. I suppose we know that MRD negativity at an early point doesn't always, and we know that many patients with an early MRD negativity, unfortunately, will relapse at a later point. It's something that's being studied in trials over time. So it is a marker that can generally predict for a longer remission, but it's not something that we can say in any shape or form can translate to a longer term cure at present. But future trials will be assessing whether we can tailor therapy to an detectable MRD with the aim of trying to knock the disease back earlier at the outset, to say, can we work towards pushing it back to the point that it just won't recover?
One of the questions that came in during your presentation was from an attendee who's been on watchful wait for 20 years. And the hematologist says that not quite ill enough yet for treatment, but the quality of life is going through the floor, to use the description. The person is aged 73. And rather alarmingly, in my view, asked the question, am I too old for treatment?
Hopefully what I've run through today shows absolutely not. I think certainly for many years, when we go back to the time that we didn't have targeted treatments, then we have for a long time had slightly more gentle antibody chemotherapy treatments that we could have, and I've certainly taken many people through, certainly into their 80s. So certainly, I suppose we're not ageist in any way. We look at an individual and over individual's fitness and other health problems and comorbidities, but certainly not. Over time, most patients needing first-line treatment or for CLL will be over the age of 70, and I've shown you the increasing number of treatments that are not chemotherapy based. Unfortunately, they're not free of side effects, and as we've heard, some people need to, as we heard from Karen earlier on, sometimes we need to stop targeted treatments for side effects, but certainly it does sound in in this case that if quality of life is starting to suffer, we would be fairly confident to say that we have options that could improve that. We can never guarantee that the first treatment we decide on will definitely improve things, but I think it's a very fortunate situation to be in, to say that we could decide on a plan A, depending on patient preference and circumstance, and then if it doesn't work, we have plan B and even plan C. So
right.
Hopefully that's reassuring.
I'm sure it is, and we should say that whilst in these webinars we don't give any very specific medical advice in response to any question, generic advice is available, and we would recommend that people talk directly to their care team. Talking about the care team, the term shared decision making is a active use. From a consultant's perspective, what do you understand with regard to shared decision making, and in what aspect is the patient involved, and even the multidisciplinary team, and how the patient would interface with the multidisciplinary team if required?
Several issues raised there. I think we've moved from a position where, as we are in many situations with blood cancers, where we don't just make a diagnosis and say the gold standard treatment is X. When we have treatment choices, I have to say in clinic it does take longer when there is choice, but it is such an important thing to do, and generally when we're thinking of treating CLL, there are rare circumstances that we don't have a period of weeks to a couple of months or even slightly longer, and then that's where we can start to introduce treatment options. There will always be people who will say, I don't really want to be involved in this, you tell me what's best. But even in that scenario, I think it's important that we have to go through the main differences between the treatments as to how many visits to hospital, what the main side effects would be, and to really make treatment decisions truly together. In terms of the MDT, the way that most MDTs work are that generally these are meetings that do move fairly quickly, discussing many cases with all of the key individuals, often involving ours, involves radiology to all of our consultant colleagues, and it's not something that we would generally recommend for a patient to be, logistically, would, especially at the moment, be able to invite patients to, but it's our job as a patient's consultant to take patients' wishes along, to be considered alongside all of the other blood parameters, comorbidities, and to reach a consensus, and then feed the consensus view or the different viewpoints back. And sometimes that happens at a local level, and if there are if there are disagreements amongst a local MDT panel or between patient and the consensus locally, then we do have a wider regional MDT process as well. So where needed, we can have wider discussion to make sure that we reach decisions that seem that everyone is agreed on.
Okay, thank you. Within that context, some patients have access to a clinical nurse specialist and some unfortunately don't. Those that do, how can they maximize the benefits that can be achieved by the utilization of a CNS?
I think it's important to stress to anybody listening that we have both clinical nurse specialists and also locally we have an advanced nurse practitioner who is also able to prescribe, but what I'm trying to say is very knowledgeable, and I think for all of our patients to know that we have direct access to somebody who knows an awful lot about their condition is hopefully very reassuring. And in terms of maximizing, just to be aware that that there is the opportunity to speak to somebody else apart from just the consultant, who may have a little bit more time to be able to speak about the treatment options in slightly more detail, and never be afraid to pick up the phone. Certainly our advanced nurse practitioner, who unfortunately can't join us today, is very proactive at giving out a card with direct contact details and stressing that really to pick up the phone no matter what it's about.
I think we're going to wrap it up at that, Alison. So thank you very much.